I'm told we are live on Facebook here on this Thursday afternoon. And I'm really pleased to welcome everybody to what I hope will be a really interesting half hour. I'm just thrilled to have with me for a Facebook Live, as I was joking on Twitter, a Himes who actually has facts and knowledge and charisma, and that's not me, that's my little sister, Katherine Himes. Who is a high-risk OBGYN at UPMC in Pittsburgh. That's the University of Pittsburgh Medical Center. And it's just great of her to take some time because she has been working flat out these last couple of weeks. And I just thought it would be really great for people to be able to understand, even as we sort of praise and support and honor our healthcare workers, kind of what their world really looks like. A lot of us know that they're working incredibly hard and putting themselves at risk, but we don't often get to, at least most of us don't get to talk to folks who are actually doing that. So I thought that we call her Cata in the Himes family. That comes from the Spanish name for Catherine, Catalina. So if you hear me call her Cata, that's what's going on there. It's Dr. Katherine Himes of UPMC. But anyway, Catherine, thanks so much for joining us.
Yeah, it's great to be here. Thank you.
Yeah. So Leal, let's start with that question. You're in the hospital all the time. You're not a respiratory specialist. You're OBGYN, but obviously this COVID-19 gets into your world. So paint a picture for the folks who are listening today of what it's actually like day to day inside the hospital and what that looks and feels like.
Yeah, sure. So actually, Jim, when you first mentioned doing this Facebook Live, I just kind of went back to look at my different call shifts over the last 2 months, and I realized that the first woman that I took care of that was suspected of having COVID was on March 16th, which I think is about 5 days after the WHO declared a pandemic. And I was thinking a little bit about what my life was like then versus what life is like now. And probably I'm not alone in saying this, but it feels a little bit like we've lived a lifetime in the last 2 months. Yeah. Things are really different now than they were in early March. And I guess it's worth saying, I would be like a little bit disingenuous to say that Pittsburgh has not experienced the surge that New York has, and my experience has not been what it would be like to be in a surge center. But back in March, I would say that we all were just scared. We didn't have a good sense then of how prevalent the disease was in our community. I remember this first patient that I took care of, who was about 7 months pregnant, came in preterm labor with an acute respiratory illness that was progressive and bad. I'm a high-risk obstetrician, so these patients come to me. I work closely with my critical care specialists, and we rapidly isolated her, had her in our, what's called a negative pressure room in our ICU. Reached out to our anesthesia colleagues about how to safely manage this woman. And I just think back on it because we were scrambling to find, the right PPE. I couldn't quite remember at that point in time how to don and doff it, which is our fancy language for take it on, put it on, and the turnaround time for the test was 72 hours. And in that 72 hours, we're minimizing the care. You're trying not to compromise care, but limiting in and out of the room, and just the anxiety of the healthcare providers taking care of this woman. And then you fast forward to just this last weekend when I was on call, and we've really been able to transform our medical system. So that when I had a woman come in with a history of asthma, about 7 months, very similar story in respiratory distress, we've run simulations. I know exactly where my PPE is. I know how to efficiently put it on and take it off. The tests come back in an hour to 2 hours now, and it's transformed how we care. And honestly massively decreased the anxiety of the folks taking care of people.
So it sounds like there's been quite a change. I mean, I can only imagine in mid-March, we were all sort of completely ignorant of what this thing was, how contagious it appears. I assume even though you guys are all professionals and you're used to thinking about this stuff, I suppose that 2 months ago, you probably had a lot of the same questions and uncertainties and anxieties that we did.
Yeah, I think that's right.
And what about, has the situation improved? So it sounds like you've gotten sort of policies and protocols and everything in order, but what about the availability of the protective equipment, and what about the availability of tests? What's your perspective there?
Yeah, I mean, I think probably you remember, because I think I remember texting you a couple times early on this. You know, the testing situation in March was bleak, right? We had very limited tests. To even be able to perform a test, we had a local command center that had to approve, you know, who could and could not get a test. Only the sickest of sicks were getting tested, which you can imagine all of us feel more anxiety when there's uncertainty, right? So, you know, if you can't test someone, but you still have to take care of them, what PPE do you use? What level of PPE? Are you going in with your full, you know, respiratory gear versus droplet precautions? It's very anxiety producing. Where I'm at, we have been able to rapidly ramp up our testing capabilities such that now, not only are we testing people who are acutely ill presenting for care, but we are, you know, in an effort to start being more relaxed and easing some of the restrictions, also testing asymptomatic people. Say you are scheduled for a cesarean delivery at term, you will now be offered a COVID test before your surgery so that we can, you know, reassure you you're negative, but also reassure the healthcare providers that you're negative, so we can, you know, care for you appropriately. You know, we still need more. I don't mean to present it that way, but things feel much better now than they did at the beginning of March.
Yeah, good. It feels that way to me too. I remember in March, I was getting panicked calls from the hospitals here in Connecticut saying we have, you know, 12 hours of PPE and we don't have nearly the testing capacity. So what I'm telling people now is that we're doing better, but we have a long way to go. Yeah. And you know, if we can take a little detour here, this will be helpful to me, and I think to a lot of people who are not professionals. Testing. As Speaker Pelosi says, that is one of the absolutely essential keys. Those of us who are not super knowledgeable on this, we hear that having adequate testing is one of the key steps to reopening or re-achieving some form of normalcy here. Can you tell folks? Because I think I mean, I spend a lot of time with doctors and public health professionals, but I have an imperfect understanding of why testing is so important to reopening and getting back to a world where we can interact. Can you give us just a couple of minutes on why that's so essential?
Well, so that's an interesting question. I think let me break that down a little bit, because at least as a medical professional, I hear two different things there. You know, the first barrier that I think we faced was, you know, while obstetrics didn't really stop through this, you know, people don't stop having babies, they're not, you know, elective deliveries necessarily. A lot of the hospital ramped down, so because we anticipated a surge, right? And so we wanted to free up ICU beds, we wanted to free up operating rooms, kind of gleaning from the experience in New York and Italy. We were really kind of preparing for needing this ability to flex up in capacity. So we stopped essentially doing, you know, elective and non-elective surgeries, cancer surgeries, surgeries that need to be done. And as we've started to open up those surgeries again, we want to be able to do that safely, also safely for the healthcare providers, right? And one of the things that none of us understand about this virus, and I think, you know, it's going to take time, is the degree to which asymptomatic people are spreading the virus. So, you know, a 60-year-old man who comes in for his cancer surgery, feels well, needs to be intubated for that procedure, you know, could he be asymptomatically spreading COVID during that aerosolizing procedure as the anesthesia team intubates him? And so that's why one of the priority areas for us has been to test people who are coming in for procedures where they may need to be intubated. And that's how we're safely opening up the hospitals. And that really gets at this issue of kind of asymptomatic patients who need to have a high-risk procedure. I think the second question that you're asking is like not in the hospitals, more broadly in the community, and that gets to this question of antibody testing, right? How many people have been exposed, how many people have formed immunity, and how well does that immunity actually provide protection against infection? And those are answers that we don't know. And I think that, you know, it sounds crazy, but it's actually not easy to come up with a good antibody test. It takes time. It takes a lot of validation. Obviously, CDC and NIH are working hard on this. And then it's going to take us time to understand what immunity means. I helped take care of actually a friend's dad who, you know, he's a 75-year-old man who got COVID, thankfully recovered. Went down right away 4 to 6 weeks after he recovered to give plasma, right, to kind of donate. And he said, you know, I'm the safest man out there. Can I get back on Meals and Wheels and start delivering, you know, to the community? And we were like, hold on a second.
Yeah.
We need to
so
learn.
that's really one of the takeaways. I mean, there is a lot. I'm sure you do it too. I spent a lot of time trying to bat down misinformation, which isn't always super easy as a non-expert. But one of the takeaways, I hope, from our conversation here, and correct me if I'm wrong, is that there are a lot of people now who have had the disease, recovered, and the fact is that we have no confidence at all that if you've had it and you have recovered, that you can go out there and be assured that you won't get it again, right? That's not something we know right now.
Yeah, I think that's fair. I think, you know, unfortunately, there's a lot we still don't know, and that's a big part of it.
But we can't definitively say today that if you had it 3 weeks ago, just go out without a mask, do whatever you want, go visit, you know, an elderly person. We can't. We're not there yet, right?
Yeah. No, I think that's fair. I think that's absolutely.
So let me raise a different but related topic. We got a question over Facebook, and I'll get to the specific question in a second, but the general question is, again, from my layperson's understanding of this, when I look at the really bad outcomes, the fatalities, and sadly, you know, we're approaching 3,000 here in the state of Connecticut, really small state. A very substantial percentage of those really bad outcomes, fatalities, are people with serious, I guess what you professionals call comorbidities, but diabetes, significant obesity. I did get a question over Facebook for somebody who said that they have very well managed hypertension and I think well managed diabetes. So can we spend a couple of minutes? How should somebody with a pre-existing condition, with some of these comorbidities that seem to open the door to really bad outcomes, what do we know and how should people think about that?
Good question. So, you know, I think that, I think it would be, you know, premature to say that we have, so again, I'm going to break this down because this is how I'm hearing it. I think there are two questions. One is, what is the magnitude of risk associated with having diabetes, hypertension? And, you know, to define how much risk is associated, we want really large, high quality epidemiologic studies that we don't have yet. But it seems like probably regardless of age, those comorbidities, those additional diagnoses kind of double your risk. You're asking a more subtle question, which is what happens if those are very well controlled. We all know that not all diabetes is created equal. Some people have incredibly well controlled diabetes with no complications, whereas others, you know, have a lot of complications. We don't have the subtlety, the data to answer that question. So what we can say is this confers risk, but I can't be subtle enough yet to say if it's well controlled, it's okay. I will raise another question that I don't know if this is on the minds of folks, but you know, when you asked me earlier when we were first chatting about this, like kind of some of the things that are on the minds of healthcare workers, you know, as an obstetrician, but I talk to my internal med friends, the hospitals are remarkably empty. You know, obstetrics a little bit less so. But when I think about the ERs and you know, the number of people presenting to ERs, and just last weekend when I was on call, I had a woman with bad asthma who had tried to manage her asthma for 3 days at home because she didn't want to come to a hospital. And so by the time she got to me, she was so much sicker than she would have been. And so for these people with comorbid illnesses, with hypertension and diabetes, like, you still need your outpatient care. You still need to get your diabetes managed, your hypertension managed, and we need to figure out a way to do that so we don't have kind of collateral damage from COVID.
Yeah, no, I mean, I'm very conscious of the fact that people's nervousness about approaching any aspect of the healthcare system, that will involve a fairly traumatic cost over time as well. You know, it's interesting, a question just came in, and let me be very clear, though we have a doctor on this Facebook Live, we are not giving personalized medical advice. I'm very careful in all of my public appearances to say that I sure don't give that advice, but anybody who's a doctor or a medical professional will tell you that to give really personalized advice, you need to have a conversation with your healthcare provider. But we did get an interesting question which precisely pertains to what you're talking about right now. We got a question across Facebook asking, how should I think about maybe taking my 1-year-old in for the well baby visit? Is that, and again, I know that every situation is different. It probably is different in Iowa than it is in New York City, but what can you tell people about, you know, non-acute, non-emergency, how should they think about that?
Yeah, no, it's a great question. You know, again, I'm just going to say, like, I feel a little bit disingenuous saying this coming from Pittsburgh. You know, we have started screening our asymptomatic population that are coming in for surgery, and our test positive rate is so low, and our prevalence in our population here is so low. But I would support people continuing to get their well childcare, particularly vaccinations for those kiddos. In some senses, doctors' offices, I mean, I don't know how it is at the Capitol, but to walk in this building, I am screened, you know, both with questions as well as temperature. You know, I am masked. I don't have it on right now. I was joking. I felt like I should wear it but we wear a mask in every environment. And that's true of the community pediatric offices as well. So, you know, if your community has low rates and, you know, Connecticut is falling, even New York is falling, I think it's really important that people continue to get their well person care. Probably you guys have seen this. I mean, one of the things that I was really impressed with our healthcare system is how massively we up, you know, our surge capacity for televisits, and a lot of things that can be done by a televisit should be. You know, obviously vaccinations don't fall in that category. A lot of prenatal care doesn't fall in that category, but what can be done by telehealth should be done.
Yeah, very early on in this horrible experience, one little piece of wisdom I was able to pass on as a non-expert was, whatever you do, call first. You know, don't show up at an ER, don't show up at your doctor's office. Obviously, you know, just calling to make sure that they're capable of dealing with what it is you have. It came up in the context of testing, right? You know, I spent a lot of time urging people not to just turn up in the emergency department demanding a test, because that's obviously a fairly high risk thing to do. So I suspect that's a pretty good all-purpose piece of advice, which is,
no, I think that's
call your
right.
your healthcare provider. So we got a couple of other questions coming in on Facebook, but one of the categories, and let me tell you what I've been kind of telling people, because I get a lot of questions like the one that just came in, which are when are we going to get the vaccine? When are we going to get the therapy? When are we going to get kind of the next generation test? And let's just spend a minute or two on that. And what I'm telling people, and feel free to publicly contradict you. That's it's your right.
I would love that.
To contradict me. I've urged people to really focus on protection, on taking the steps that we all know we need to do now for social distancing, and to keep track of progress being made on vaccines. But it's a complicated thing, right? Because our tests are not 100% accurate, and that raises all sorts of epidemiological issues that must admit I don't fully understand. A vaccine, just because there's a eureka moment at Oxford or at Shanghai or at MIT or at Stanford that there is a vaccine with some promise, that's just the first part, right? If we have a vaccine, there's 7.8 billion people on this planet, and in some ways, actually producing the vaccine at scale, that is a project probably unlike anything the human race has undertaken, right? So we're talking about months and months, even if all of a sudden we had an effective vaccine. And so I guess the point I'm making to people, and I'd love to hear your expert opinion or what you'd add to it, is that the emphasis that we should in our day-to-day lives, our attention should really be on being scrupulous about keeping ourselves safe and people around us safe. And by all means, monitor what's happening with vaccines and therapy, but this is a long haul thing, right? The probability that we wind up in a world where we have a vaccine soon, or a dramatically different testing regime, or even a therapy really soon, that's probably unrealistic, right?
Yeah, I mean, I think there have been some really interesting articles talking about how long vaccine development happens and the costs of doing it quickly. And, you can take the experience of something like rotavirus, which took almost 25 years to develop, versus Ebola, which was fast-tracked and but it's not around the corner. I think one of the things that must be hard for people, because it's hard in the hospital where I'm constantly reminded of it, is this tension between needing to remain vigilant and continue to socially distance with the amazingly difficult sacrifice that people are making every day. And I think I said this to you earlier, it sounds a little cheesy, but never in my lifetime have I seen global altruism of this nature, of people choosing enormous personal sacrifice to stay home and try to tackle what is a unprecedented problem for us. And it's hard to maintain self-sacrifice, right? That's a hard thing to do. And I think that if, the bottom line is if we start to, limit social distancing, we're going to see more infections, and how we handle those infections, what we're able to offer people, will matter a lot. But because we're so far away from a vaccine and from effective therapy, we need to try to delay big surges and outbreaks as much as possible. And I think that's why, you see this on the news, right? This isn't even needing to be a physician, don't open until you've had, 2 weeks of infection rates falling, until you know that you have testing capability to understand the community prevalence, until your hospitals have adequate capacity, until we have a better understanding of immunity. It's just the long haul is hard. I'm a mom of 2 kids that are home without any chance of going back to school. The tension's real.
Yeah.
Hard.
Yeah. Let me just hit you. We don't have that much time left, but let me just hit you with a couple other questions that I think are largely rooted in the confusion that lay people have. And then I'm going to ask you to close out with kind of what you see with your trained eyes happening out there that is good. You talked about the sort of philanthropic instinct that you're seeing, which I agree with you on, but you're probably seeing some things that concern you. But before we get to that, which I think is a good place for us to close up, really interesting question just came across, and I'm steering away from some of the very specific scientific questions, but there's a really interesting question, a little like testing. The word is out there. I'm not sure people fully appreciate it. We hear a lot about herd immunity. And I know that there are a lot of people inexpertly using the concept of herd immunity. I even, in my world of politics, which is probably in some ways the opposite of your world, in as much as objective truth is sometimes not what it's all about. So we even hear people saying, you ought to go out there and, get infected because, well, that'll help achieve herd immunity. Can you just, in layperson's terms, can you talk a little bit about what herd immunity is, how we get there, what the positives and negatives about getting to a world of herd immunity are?
Well, it's funny. The last time this came up for me, which is maybe an easier example for people to understand, is maybe 6 months ago we had some measles outbreaks, and measles is a example of a disease that we have a very effective vaccine for that most kids receive. So we're talking 90% plus of people have immunity against measles, meaning if they were exposed to the woman with measles, they won't get measles. So the way this comes up is, say somebody chooses not to vaccinate for measles, chances are that person's going to be fine, right? Because the vast majority of people in the population are immune to measles. So even if there's one measles case, it can't kind of spread like wildfire because it gets damped down by that herd immunity. And so, it's much easier to contain and stop these kind of outbreaks of measles because most people won't be susceptible, even though it's an incredibly infectious disease, right? Like really easy to transmit. So, coming back to COVID, you're talking about needing something like 70 to 80% of the population to be exposed, form antibodies, and have those antibodies be effective enough that you can't get the disease. Like, we're so far from that, right?
We just talked about this, right? We still don't know that you could even have herd immunity because we don't know that that the antibodies are. We don't know that if you get it and recover, that you can't get it again, right?
Right, and even in New York, where some of the estimates suggest that 20% of the population has been exposed, look at the cost to getting there. In a place like New York. So, I think it's easy to talk about how, this predominantly affects, our seniors, the elderly. Listen, I'm anchored in my own bias. I don't take care of that population. And we have a 19-year-old intubated in our ICU that we did, had to deliver. And, she's battling COVID right now. So one, it's not just a disease of the elderly. It's a disease of the elderly, of communities of color, and a disease of poverty, and the cost of getting to 70 to 80% with this idea that we should do COVID parties seems, it seems a little crazy to me.
Yeah.
And who knows if it's effective.
Yeah, right. That's really helpful. I mean, I think we should be very skeptical about a lot of the assumptions that underlie the possibility of herd immunity, much less the ethical issues. As you say, New York has been absolutely devastated. I wasn't aware that New York has 20-30% exposure. But the cost that would be paid, even assuming that you could get herd immunity for this pathogen.
Yeah. It's horrifying.
We're running a little low on time. There's two last questions I want to ask, and they're both sort of practical questions. One is a little bit almost political. The other one is more about what people should be doing. The more political question comes from actually a friend of mine who just put it up on Facebook, who said, what, as a doctor, is your opinion about the very aggressive efforts to open up in areas of the country at a time when it appears like we haven't really ticked all the boxes that we would want to tick, whether it's testing or surveillance or contact tracing or hospitals being. So that's sort of a macro question. What do you think of these reopenings? And I know it's a complicated answer, right? Because again, North Dakota is different than the Bronx, right? But we're not scientists. That's question number one. And then let's close out with your opinion on, you talked about something that you saw that was happening that made you feel good, which is sort of people's philanthropic instinct. What are you seeing out there that individuals, the people who are watching us right now, ought to think about in terms of their own personal behavior, things that make you nervous, that you see happening out there?
Yeah, sure. Yeah, so with regards to the opening, I think I alluded to this. You don't need to do anything more than read the headlines of the New York Times, which vacillate between, highlighting the 70,000 plus Americans who have died in the last, 2 to 3 months versus, the 1 in 5 children that are going without enough food to eat because of the economic collapse, to understand the complexity of this. So I'm gonna just put that out there and acknowledge that it is hard. And you said something really important, which is that North Dakota is not Manhattan. And so typically, I think we would look to the CDC for some kind of national guidelines about how to go from red to yellow to green, right? I think that there has been some guidance that would indicate if an area has 14 days of decreasing tests, if you're able to do effective contact tracing, if you have accessibility of testing. There's been some guidance, but I would like to see more granular data and recommendations from the CDC on when communities can start lifting things. And we're not seeing that kind of federal level guidance come out. We need to define yellow. We can't just go from lockdown to go back to your mosh pits, right? Because I do those most weekends, somewhere that we need to start to paint the picture of what yellow looks like. How do we safely get kids back into daycares? How do we, do these things? And I guess this is more back at you, Congressman. I would love to see the federal government providing a little bit more granular recommendation to help communities so that it can be driven by data as opposed to, just this sense of outrage that I can't get my hair cut.
Yeah. Okay. Only now are people getting a little bit of a sense of what a Himes family Thanksgiving dinner actually looks like. Yeah, no, that's right. It's funny. I was thinking exactly what you were thinking, which is that, as somebody who's an elected leader and who has a platform, candidly, I'm not sure that I can give people good advice on what yellow looks like. And of course, in addition to the healthcare professionals, that will be the political leadership that people turn to for that. And so that feels exactly right.
Yeah.
So yeah, that's something for us to work on. So let's just close out. Again, you look at what's happening out there with a much more professional and trained scientific eye than the rest of us do. What do you see out there in terms of people's personal behavior that concerns you? And I'm not just talking specifically about somebody went to a store without a mask on. As you rightly point out, there is a healthcare cost to isolation.
Yeah.
There's a healthcare cost to lack of access to food. So I'm just curious about what you see at the micro individual level out there that worries you.
Yeah, I mean, I think I mentioned one thing, which is certainly in Pittsburgh, and I think, even in places that saw more of a surge, I am beginning to get increasingly concerned about what people's lack of engagement in healthcare means for them and their well-being. So I gave you that example of the asthmatic that I took care of this weekend, who clearly put herself and her pregnancy at grave risk because she was desperately trying to avoid the hospital. I think we need to start recognizing, call first, but you have to continue to get care. So that has been a real concern. I guess the only other thing that I would say is that we all need to have compassion for ourselves and others. This is unprecedented and hard. And I think there are a lot of people really struggling. And so to the extent that we can reach out with compassion and kindness, and again, I can't help it. I've been in the hospital so much. I have women laboring now with just one support person, you know, people coming to visits where we're talking about, you know, life and death decisions for their babies, and they're on their own. Like, everybody is struggling, right? And, you know, you see these reports of people pushing park rangers into ponds because they're asking you to socially distance, or like worse, you know, the gun violence surrounding, you know, requests for masks. I just wish like we could continue this like compassion for one another, and you know, reach out for mental health help if you need it. We have this huge surge of mental health calls here as people are just feeling really isolated and struggling. And so, you know, we all know to wash our hands and wear a mask, but don't be afraid to reach out for help from a mental health perspective if this is kind of really preying on your last bit of resilience.
Yeah, no, that's great advice. I've been sort of tossing around in my own head in my copious free time these days. I've been tossing around in my own head what is not a very smart comparison, but you know, in my lifetime, I've seen a couple of true national crises. And I've been sort of comparing the way people are responding to this very, very serious health threat, this national security threat. You know, last week we blew through the number of Americans that we lost in the Vietnam War, and we're losing 2,000-3,000 a day today. I'm comparing that to how we responded to 9/11. And I've been sort of thinking about the fact, and obviously the comparison breaks down in 1,000 different ways, but maybe it doesn't break down in the way of what we were willing to do to mobilize afterwards. And I'm intrigued by the notion that after 9/11, because the enemy had a face, and because we could fit it into the way people think about things, good guys, bad guys, good, evil, we were really together. We were, and I was there on 9/11, and from the moment it happened, I remember in New York, of all places where people are so fractious and, you know, rude and loud and everything, we were really together. And that lasted for a very, very long time because we could fit that into sort of a good versus evil, and we were the good guys, and people were signing up to join the Marines and the Army and the Navy, and we, you know, and it just, and that was sustained. Here we've got something that we can't fit into our way of thinking about stuff. There's no story that tells us the role that we need to play. And I've been sort of intrigued by the notion that, as you say, reaching out, we've got to figure out a way, even though the enemy, as the president likes to say, has no face, it's invisible, and it can be transmitted by all of us. We've got to find a way to find that sense of unity, so that when you see somebody go by not wearing a mask, to your point, the answer is not to scream at them. The answer is to somehow engage in a way that is socially supportive, psychologically and emotionally supportive, and that leads to a good outcome.
Yeah, right.
Well, here ends the sermon. I'm not quite sure where that all goes.
Yeah. Well, and you know this, I don't know, you acknowledge it breaks down. I mean, this is a sustained effort that is asking absolutely everyone to sacrifice a lot, in a way that not everybody sacrificed a lot after something like 9/11. You know, it was unique who paid the price there, you know, and who stepped up to serve. I mean, I guess the one thing I would say is, you know, I am extraordinarily grateful that here in Pittsburgh, we have not had the surge that you saw in New York. And that thanks is because we had aggressive social distancing. I mean, we went on lockdown, I think, you know, March 16th, and people have complied. And I know that it's hard, but I think if we can hold out a little bit longer and paint the yellow a little bit more granularly so we know how to do this safely, we could really help out what things are going to look like in the fall and the winter of next year, right? Because this is the long haul. Yeah.
Well, Katya, I gotta thank you. Really, thank you for joining in. And as I said on my Twitter feed, dropping some knowledge here. A big part of what we need to do is hear from people who really know what they're talking about, and to reassure people and to you know, get that information out there. So thank you. I had an ulterior motive too, which is I have been so jealous of Andrew and Chris Cuomo on CNN and those two guys. And you know what? Not only did we drop knowledge, but you didn't call me a meatball. We didn't have to summon mom. So you know what, Cuomo brothers, we're coming at you.
For you. Love it.
All right. Well, we're going to close this out.
Right
Thanks
on.
so much. I know how
Yeah.
busy you've been. It's really great that you joined us for this.
Totally my pleasure. Thanks. Take care.
All right. Okay. Take care, everybody.